Hi, Mike Gibson, Steve Nissen. We're coming to you live from ACC 2026, and we're talking about the SURPASS cardiovascular outcome trial looking at tirzepatide versus dulaglutide. Steve, this is an expanded analysis looking at some of the cardiorenal outcomes. Talk to us a little bit about what you found.
Okay, well, it's important to understand that the Surpass CVOT was designed in collaboration with the FDA. The Rewind trial had studied dulaglutide compared with placebo, and it shown superiority. But it was felt that there was no longer appropriate to do a placebo-controlled trial now that there have been several favorable trials with GLP-1 agonists in this population with diabetes and cardiovascular disease. So Surpass CVOT used the same endpoint as Rewind, cardiovascular death, MI, stroke. And it was a non-inferiority trial with at least the possibility of showing superiority, led by Steve Nichols. And what it showed, published in the New England Journal of Medicine late last year, is that tirzepatide, the dual agonist, was non-inferior to dulaglutide, but it didn't reach statistical significance for superiority. The p-value was around zero point 0.8 or 0.09, zero point 0.08 or 0.09 for superiority. But we have known for a long time that this class of drugs, these incretin drugs, do a lot more than simply alter that core MACE three-component endpoint. For example, they reduce infectious death, they reduce death due to cancer and other things. In addition, many contemporary.
That's why, Steve, sorry to interrupt. That's why you and I both agree that all-cause mortality is an important endpoint in these trials.
I completely agree with you, Mike. And in fact, we're doing a trial known as Surmount MMO, where all-cause mortality is in fact included.
Mm-hmm,
In
mm-hmm.
addition, as you know, many contemporary outcome trials also include coronary revascularization. And we also know that the GLP-1 class of drugs, that the incretin drugs, reduce HFpEF and they reduce renal failure. So all these events had been adjudicated, and what I proposed is that we analyze the totality of benefits of these drugs, comparing the dual agonist tirzepatide to the monoagonist dulaglutide. Well, the result was very striking. There was a p-value of less than 0.001 for improved outcomes. I would have to say in association with improved outcomes because this was a secondary analysis. Um, and the hazard ratio is 0.84. So compared with an active control, this is first active
Active
control
control,
trial.
not placebo, right?
Yeah, first active control trial in the entire field of incretins. First active control cardiovascular outcome trial. So, and interestingly enough, all-cause mortality in and of itself was statistically significant in comparison. And we also did sensitivity analyses looking at a five-component endpoint without the renal component, a four-component endpoint without the heart failure or the renal component, was all very consistent. A hazard ratio in the range of 0.84 to 0.85 for all these endpoints, showing better outcomes with the dual agonist. And it was particularly driven by all-cause mortality. We think it's important because we have to choose what drugs to use in what patients. And the question always is, is the next generation of drugs better than the past generation? And that answer was not known. But I do think that although it is a post hoc analysis and therefore should be considered hypothesis generating, the results are pretty striking. And I do think they inform clinical practice, even though they will not inform regulatory policy.
So, Steve, this trial, I think, correct me if I'm wrong, was largely done during COVID. Is that correct?
Yes.
Do you think that COVID and the inflammatory response and all those COVID-related deaths, do we know if those people did better on tirzepatide in terms
Well,
of
yeah,
mortality and everything?
yeah, we don't have that information, but I will tell you that Dr. Minian and I published a manuscript on people that had had bariatric surgery who got COVID compared to a control group, very carefully matched, that had not had bariatric surgery. And there was a striking reduction in mortality from COVID in those people that had lost weight. And I think everybody pretty aware that obesity increases cytokines produced by abdominal fat cells, which are part of the inflammatory response to COVID that's related to the morbidity and mortality associated with it. So I think the learnings here are that obesity has a plethora of adverse consequences. And that if you really want to study the effect of a drug that reduces body weight or any incretin, it's probably prudent to have a broader endpoint because you can then capture all the benefits and harms associated with the therapy.
Well said, Steve. Thanks for joining us today, and thanks to all of you for joining us here live from ACC 2026.